Thank you very much. Thank you very much for this kind introduction. I'm very happy to be here in this wonderful city, this wonderful climate, sunshine. I'm very sorry for all of you to be here in this dark room. And my topic is uterine fibroids, anything new? And I could make my presentation short by saying, yes, thank you very much, coffee pause. But I think this would not be fair to you if you're interested in hearing more than that. And first of all, my conflict of interest, I have a few other obligations, and I also do get a bit of money from it, but I think it does not interfere with my presentation. Now, what is not new is that we know that there is in Europe a fairly high percentage of 40% of women in reproductive age that is affected by uterine fibroids. And what is also not new is that the hysterectomy, mainly due to benign reasons, is also the second most common intervention in gynecological surgery. And this is something that we might consider to change, because the motto of this conference is best clinical practice for women. And this is something that we have to obey and that we have to consider. Now, what is the right therapy for each patient? It is that we have to bear in mind the severity of symptoms, the size and position of the fibroids, as has been outlined in the first speaker this afternoon, age of patient, desire to keep the organ, as was mentioned also before, that in a patient that desires fertility, we should be really careful in maintaining the organs, which is also the next point. We have to consider medical risk factors, and which is not the least, the experience of the gynecologist and also the experience of the surgeon. So only enroll into something like that if you are experienced. I am a surgeon, and this is where I earn most of my money with, but I have to consider medical treatment. And if you look at this list, and I hope the pointer works, you can see on the left-hand side the approach. The first three ones is oral contraceptives, progestins, and levonorgestrel IUD, which is known as Mirena, is not listed for treatment of uterine fibroids. What is listed is GnRH analogs, and what is new, and this is, which I'm also presenting to you today, which is not even available in your country, but I have 5 years of experience with this drug, because it was listed first in Germany and UK, but due to the reimbursement system of UK, it was not used much. It is ulipristal acetate, and I will tell you more about that. But what I also want to point out is, and which was new to me when I started quite some years ago to deal more with this medical treatment of uterine fibroids, that it is not exclusively or mainly estrogens that stimulate growth of fibroids. It is more so progesterone. The influence of progesterone is more impressive than the influence of estrogens. And this can be seen that we see that in the progesterone active phase and the secretory phase, there is a higher mitotic activity in fibroids, not in the myometrium, but in fibroids and leiomyomas. And also, we know that the size in leiomyomas increase in the first 10 weeks of pregnancy, where we see a dramatic increase of progesterone. And next, and this is something that I really want you to take back home, because this might change your attitude to fibroids, it is that we know that when fibroids are treated with progestins, also including Mirena, we see that there is an increased cellularity and mitotic activities in these fibroids. And when we see that postmenopausal women that are treated with estrogen and progestin, it results in a higher proliferative activity than if they are treated with estrogens alone, which is very, very important, because normally people don't believe it is, because it's like a reflex. When there's a bleeding disorder, we have an approach where we give progestins. Last not least, and I think this is very, very interesting, if a woman is treated with GnRH agonist plus progestins, there is no reduction in fibroids, which I think is very important. Now, there is a cure for that, and that is quite obvious. We know that we have anti-progesterones, mifepristone and onapristone, but we also have this group. I'm very sorry, the pointer does not react, at least to me. And we see there is a middle group of ulipristal acetate, referred to as UPA, and ezoprisoneal and others. And right on the right-hand side is the agonist, which is progesterone. And you can see here, the group in the middle is called SPRM, selective progesterone receptor modulators, kindly referred to as SPERMs. And UPA is one of them, which means that they have agonistic and antagonistic activities. A modulator does not only inhibit, it also can activate, which is, I think, important to know. Now, when we compare these substances that are indicated for treatment of fibroids, we can see we have GnRH analogs and we have SPRMs. And GnRH analogs exclusively acts on the hypophysis. So that means that there is a downregulation of the hormonal secretion with all its advantages but also disadvantages. The SPRMs barely act on the hypophysis. However, it does act on the endometrium and the uterus, which is fine.
Yes.
This works. Let me see. No.
Okay.
No. No problem. Now, what does it mean when we talk about selective progesterone receptor modulators? It works. It means that we have three mechanisms whereby UPA works. One is suppression of proliferation. Second is suppression of angiogenesis. Just so. No, not the advancing. It's the pointer.
The pointer.
Yeah.
The pointer. You can use this.
No, it.
Because it's LED screen, you cannot see the laser.
Okay. So it's suppression of proliferation, which is important, suppression of angiogenesis, what we also know from many other substances, including progestins, but, and this is, for me, this is the most important point, induction of apoptosis. This is the most intelligent approach of curing something. Now, this has been published in a very high-profile papers, mainly by Jacques Dornet, and these are the Pearl studies, and I will report about these studies next. When we have a symptomatic fibroid, one of the most, at least for my patients, one of the most important symptoms is bleeding disorder. Therefore, induction of amenorrhea, to me, is the most important point. And as you can see here, it is within 10 days, we have hardly any more bleeding. And this is irrespective of whether we have 10 milligrams or 5 milligrams of UPA. The form it is available in most European countries is 5 milligrams UPA, and we can talk about that later. If this is compared with GnRH analogs, you can see here the blue line is UPA, very rapid induction of amenorrhea. When you look at GnRH analogs, maybe because of the flare-up effect that we induce with GnRH analogs, it takes up to 1 month until we have amenorrhea. This is very important. My university is very close to Frankfurt. There are very ambitious young women that are bankers, and bankers have money, not always their own money, but they have money, and they want to travel, and they say, "Oh, doctor, I have a trip tomorrow and I have this bleeding problem, what can I do?" Even though there might not be an underlying fibroid, but this is one way we can help these women using ulipristal acetate as a substance. Now, when going back to the history of this substance, we can see there has been a study, placebo plus iron supplementation and UPA 5 and 10 milligrams. This is superior to just iron supplementation. But of course, iron is also very important. We can increase the hemoglobin level just by using UPA, but also giving iron supplementation helps a lot. Next very, very important point is quality of life. Nothing is as important as quality of life. So what can we say about the comparison of uripristal acetate and GnRH analog leuprolin acetate? You can see this is sort of comparable baseline from patients before treatment, and here we can see end of treatment, and everything below the green line is sort of healthy women. But you can see there is a significant stronger reduction after UPA than after leuprolin acetate, and that is not surprising because with the GnRH analogs, we always have the hypoestrogenism, which is causing sort of a reduced quality of life. Here you can see pain and quality of life, and once again we can see a dramatic drop in pain after the first cycle of treatment, which is 1 month of UPA. And you can also see here, if we have the consecutive UPA cycles, it still is significantly reduced, but is not as dramatic as the first time. There's no explanation for that, but still, this is absolutely sufficient to show this. When compared with GnRH analogs, you can see no statistical difference between UPA and GnRH analogs. It is more or less the same level. Next is looking at the estradiol level, and you can see estradiol levels following UPA treatment, whether it's 5 or 10 milligrams, stay normal, whilst after GnRH analog treatment it is dramatically reduced, which is not surprisingly also explaining why we have more hot flushes with the GnRH analogs than compared with UPA. That we also do have some hot flushes over here is something that we find quite often in clinical studies, where when you ask someone, do you have hot flushes, do you have headaches, there is a group of people that would always say, oh yes, yeah, I think I have hot flushes. One very important point, when you compare GnRH analogs with UPA, one thing that I think all of you will have also observed, if you treat a fibroid with GnRH analogs, you will see that the fibroid shrinks, which also makes it a little more difficult in operating because it is like a dry orange which you have problems peeling. You know, it is dried up, and so it's not so nice. However, if you wait some time, and this is now 25 weeks thereafter, you can see that the fibroid has already picked up growth until it's the same size as it was before. What we can see with UPA is that it stays like that for some time. It is a sustained effect, which can easily be explained by the fact that with UPA, we have more of an apoptosis. There is a change inside. It's not just the lack of hormones like estrogens and progesterones. So in comparison, what is the safety profile? The safety profile is fairly high for both substances, UPA and GnRH analogs. However, we have a higher bone resorption with GnRH analogs. We have more hot flushes with GnRH analogs. That's comparing these two substances. So meanwhile, uripristal acetate, UPA, has become the gold standard of treatment, medical treatment for symptomatic uterine fibroids. Also pre-therapeutic, pre-surgical. And this has entered at least our guideline in Germany. It has been explicitly named to introduce this. There's one aspect that needs to be known and familiar to any person that deals with UPA. When we perform a treatment, we can see, not in every case, but in many cases, that we have an increased thickness of the endometrium, which is called progesterone receptor modulator associated endometrial change. We have a thickness that is above 16 millimeters, and a lot of people are reminded of tamoxifen, which can increase a change in the endometrium, which can finally lead to endometrial carcinoma. This is completely different. PEG, the progesterone receptor modulator associated endometrial change, looks like a hypertrophy, but it is associated with glandular cyst dilatation, and we can see low mitotic activity. Since I have been dealing with this substance from the very beginning, of course, my pathologist has been asked, please do all measurements and whatsoever, and it is absolutely clear. What we can see is that within one endometrium, we can see that there are clusters of cells where we can see that there is an estradiol activation, and others where we can see there is a progesterone activation. But all in all, it is that there is more dilatation and cystic formation, but no mitotic activity, which means that what we can observe is that immediately after cessation of treatment, after the first bleeding, the endometrium is normal again. And therefore, what we can see, please, if you observe a PEC, no biopsy, no curettage, no threat, nothing to the patient, but this is fine. So there is no sign of hyperplasia under UPA treatment. There's clear differentiation from pre-malignant disease, not even malignant, but even pre-malignant disease. It is definitely benign, and it is definitely reversible, which is very, very important to know. And if you want to know what is the core part of UPA treatment, please keep this graphic in mind. It will be easy for you to tell your patients, you see here is the outer cell membrane, and there's the nucleus, and there is one enzyme which is called caspase 3, and caspase 3 is the key enzyme for apoptosis. And you can see here that cells from the fibroids has been investigated, and we can see here in those cells, and this is dependent on the concentration of UPA, caspase 3 has been upregulated. So what does it mean in the final effect? We can see this chart, and this chart will explain to you why I personally feel that this is not only named the gold standard, but it really rewards being the gold standard. If you look at this very simple table, you can see that round about 80% of patients see that there is a reduction in volume, which to my personal mind is not the most important point of it. But it is that nearly only 2% do not have amenorrhea. This is very important. 98% of patients undergoing UPA treatment are an amenorrhea, and this is unmet in any other disease. When comparing apoptosis with necrosis, we can see on the left-hand side, apoptosis is a controlled process, whilst necrosis, which we observe in uterine artery embolization, in high-focused ultrasound treatment, or in myolysis, or whatever, this is associated with inflammation, and inflammation means pain. And those that have experience or even practice UAE, they will see that this is the case. One patient, 34-year-old, a lot of problems, thrombophilia, whatsoever, which does not allow hormonal treatment and which did not work. She has this huge uterus, and she underwent UPA treatment. We could see the shrinkage, only 1 centimeter, but 1 centimeter when it comes to volume is quite a lot. And she finally received organ-saving surgery, and therefore is fine and is open to have to conceive. I'm showing this graph to also explain why, to me personally, the company that probably will finally market UPA also in Lebanon might not be happy to hear so. But when you talk about volume reduction, you can see here, this is 6 centimeters in diameter, and this is 5 centimeters in diameter. This means 1 centimeter means 50% volume reduction. But you will never do all these measurements and perform a volume calculation, because at a normal day gynecological practice you just have the diameter, and it is fine if you just do the measurements of the largest fibroid. And then it will be disappointing for you and disappointing for your patient if you have announced, we will reduce your fibroids to 0. This, in most cases, will not happen. However, there is a dramatic effect on the fibroid. Maybe you want to remember this list, because this graph can show you, how to deal with this patient. The most important thing is there is one group of patients that might benefit from immediate surgery, and this is the group of postmenopausal patients when they have symptomatic fibroids, and when malignancy is ruled out, schedule them for surgery. Of course, malignancy also has to be ruled out with all others, and I have one case that was referred to me by a small clinic for gynecology, and they have treated a sarcoma because of bleeding with UPA. When you treat, I hope you will never do so, but in case you treat a sarcoma because of the bleeding with UPA, the bleeding will definitely not stop. So if any one of you observes you treat a patient with UPA and the bleeding does not stop, please be aware of that there will be, most likely there will be malignancy behind. And then, be careful with what you're doing. So, I'm coming to the end. There are contraindications, and of course that is with all the biosubstances of the formulation. Of course, pregnancy and breastfeeding is contraindicated, which is normal. Genital bleeding of unknown reason and other reasons than uterine fibroids, which I just mentioned, very important. Patients suffering from cancer of cervix, endometrium, or breast. This is the official norm. But I expect that selective progesterone receptor modulators might become an important tool in our hands when it comes to treatment of breast cancer, because so far we are treating estrogen receptor breast cancers with SERMs. However, we don't do anything with progesterone receptor positive breast cancers. This could be one way, and I know of the Karolinska Institute from Stockholm that they have used progesterone, antiprogestins like mifepristol, and they could see in cell cultures that there is pronounced effect. And of course, long-term continuous therapy should be avoided just because there are no data available, and therefore the company has to say so. In conclusion, bleeding control is extremely convincing, and please get your own experience in that respect. Fibroid volume reduction, okay, on a scientific basis, this can be proven, but you really have to make measurements in order to measure the volume. If you just measure the diameter, it could be overlooked. And the results of this study indicate that the use of more than one course maximizes the potential benefit of UPA treatment, which means long-term intermittent therapy is 3 months treatment, 2 months off. 3 months treatment, 2 months off. And that is also saving money, because since there is this sustained effect, sometimes if you know your patient, it is not 2 months off, but it can be 3 months off, 4 months off, or 5 months off, or what I have seen maximum is 9 months off until the patient reported to me again in order to say, I think we need to do another treatment. And these are the patients that do not want to undergo surgery. There's also the group of patients that are the radical ones. They say, no drugs, I want to have surgery now. But they are more a minority. And as I think this is very important, we need to know that repeated courses of UPA did not increase the incidence of PEC. So it is rather the opposite. The PEC is more pronounced at the end of the first cycle, and if you have with long-term intermittent therapy the second cycle, you have less PEC or even nothing. Last not least, what I'm always asked, how about if you perform this type of medical treatment, how about myomectomy? And I can assure you myomectomy is not affected. Sometimes what you see in a fibroid that has not shrunk is that it has sort of a structure inside like gel, so that you can suck out some of the substance. But in comparison to GnRH analogs, the peeling out is as easy as without any medical treatment, definitely pronouncedly different from GnRH pre-treatment because, and as you know, the estradiol level is the same as without any treatment. So there is a pronounced difference. And by saying so, I thank you for your kind attention.